Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. Got a great episode for you today. Our topic is new solutions for lung ventilation perfusion analysis. And our guests are Dr. Greg Mogel. He's a radiologist who is chief medical officer of 4D Medical, and Dr. Trishul Siddharthan, a pulmonologist and associate professor and director of clinical research in the Department of Pulmonary and Critical Care at the University of Miami. Gentlemen, thanks for being with us today.
Thanks for having us.
So let's start with introductions. Greg, can you tell us a little bit about yourself?
Sure. I am, as you said, a practicing radiologist. I've had roles in the Department of Defense, in academic research, and now in industry. And as chief medical officer of 4D Medical, I help oversee our clinical trials, our evidence generation, and everything that requires to take our technologies, which we have a number. I know we'll only be talking about one today, but a pretty broad portfolio, taking those directly to radiologists and helping them integrate them into their practice.
All right, very good. Trishul, how about you? Can you tell us a little bit about your role there at the University of Miami and also your area of research focus?
Yeah, so I'm an associate professor at the University of Miami with an interest in pulmonary and critical care medicine and a specific focus on COPD and asthma. I'm interested in imaging phenotypes as it pertains to diagnosing disease as well as identifying individuals that are at risk for morbidity and mortality from disease.
Very good. So we're talking today about ventilation perfusion studies, and this is a type of lung function study that's been performed for decades. Greg, can you tell us a little bit about what these studies, also known as VQ studies, are for?
Sure. VQ studies, which historically are performed in the nuclear medicine department, which is related to and often part of the radiology department, are studies that use radionuclides or radiopharmaceuticals, that is, tools that that are injected into the patient, materials that the patient breathes in or has injected, which then emit radiation, which we can see under the appropriate hardware. So, what's really wonderful about this aspect of medicine is instead of just showing us the structure of things, it actually shows us where the blood goes, where the air goes. And it's actually, this kind of functional imaging is a broad part and a growing and important part of medicine, I think, historically limited by some of these older technologies that have some drawbacks, given how long they've been around, and some of the ways in which they're acquired. But understanding how the lungs work, not just from how they look, which we as radiologists are very comfortable and confident with what the lungs look like. Chest x-rays, chest CTs, these have been around for a long, long time. But how the lungs work is generally the domain of our pulmonologist friends. And so these studies where we bring functional imaging brings us together in problem solving, I think, a lot more effectively.
Very good. Trishul, you're a pulmonologist. What would you typically order a VQ study for?
A range of things, and I just want to sort of echo what Greg was saying, in that I think functional imaging basically brings in the structural component that radiology is very used to, but also the functional component. And when we think about pulmonary medicine, I treat patients, obviously not images, and dyspnea, or that feeling of shortness of breath, is strictly related to that component of ventilation and perfusion. And so we order VQ studies when really identifying individuals with shortness of breath. So we look at things like chronic pulmonary embolic disease. We assess it sometimes with COPD. We assess it with a range of other respiratory conditions where there is ventilation and perfusion mismatch that really signifies what is the underlying cause or etiology of dyspnea.
And so are these like dynamic studies that are actually showing the lung as it functions?
Yes, in some sense, right? And so it is an inspiratory and an expiratory CT. And we've been doing this for years for a pulmonary fibrosis, another one disease entity. So it is a standard practice. However, there's very few organizations that have actually incorporated a quantitative component. And so looking at the difference between the inspiratory and the expiratory effort, the additional value is really perfusion here, right? And so we can say what is the difference between an inspiration and an expiration on a CT, but when you combine perfusion to that, it really adds an additional level of detail that helps us understand what's going on in the lung as an individual is breathing in and out. So it's a functional aspect that goes way above and beyond the traditional CT scan.
Very good. Now, Greg, you mentioned that nuclear medicine technology, radio tracer technology is typically used in a VQ scan. What are some of the shortcomings around that?
Well, there's a few. I mean, first of all, unlike most studies that require some form of material to help identify what's going on inside the patient during imaging, actually, this study requires two different ones because you're studying both the blood flow in the lungs, which can only be accessed through putting something in the patient's bloodstream. Pretty common. We do that with MRI, we do that with CT contrast all the time, but also uniquely requires them to inhale a very specific radio tracer that then goes in the lungs and circulates in the lungs. So maintenance of that radio tracer, keeping it around, keeping it active, keeping it, if you will, I'll say fresh, but there's far more technical terms for that. When it's really only used in that one clinical application is expensive. It has logistic issues. And then I'd say also significantly from a patient perspective, um, it's actually compared to CT or compared to many other imaging technologies with which we're much more comfortable. It's very time consuming. It requires a long period comparatively of image acquisition. So a patient is directed to lay quite still and have this material put into their lungs and breathe normally, which for some of these patients is not easy to begin with. They're there because they have pulmonary symptoms, and sometimes smooth, regular, continuous breathing is not the easiest thing for them to do, to lay motionless for a long period of time. So in the end, there are significant logistical limitations in the hospital itself. There are limitations in the patient experience because of the length of time that it takes. And there's a relatively small cohort of nuclear medicine specialists who routinely interpret these studies. And they are often quite busy interpreting other studies that compete for their attention. So there's quite a few limitations for the health system, the patient, and even the physicians involved.
Okay. Now, your company, 4D Medical, has developed an alternative to nuclear medicine-based VQ called CTVQ. Can you talk a little bit about what CTVQ is and what sort of clinical gap it fills?
Yeah. So for several years now, we've had a commercially available, validated product called CT ventilation analysis, which shows in detail the function of the lungs in CT without any inhaled radio tracers. So we take a traditional, as Trishul pointed out, inspiratory, expiratory paired CT, and by comparing the two and simply performing a mathematical analysis on the data within the images can provide a detailed map of ventilation inside the lungs. Ever since the first day we showed that to people, the immediate question that would follow was, what about perfusion? When will you have perfusion? And so we're really excited that just recently, just about 2 months ago, we received FDA clearance for our perfusion technology, which is pairs with our ventilation technology. So, I think the most important thing for people listening to or watching this podcast to understand is that we take an absolutely traditional CT scan that can be acquired on any CT scanner, not using any injected contrast, inhaled contrast, not requiring any unique protocols that are difficult to carry out. In fact, we can perform this retrospectively on inspiratory, expiratory CTs that may be 5 or 10 years old. So you can actually look at this longitudinally and essentially produce, with only a computer analysis of those images, a very detailed study that provides both qualitative and quantitative information of exactly how the lungs are working, both from a ventilation and perfusion perspective. And so the patient undergoes no additional evaluation. The patient has no exposure to injected contrast or radio tracers. It is simply an analysis. So I think the ability to provide Trishul and his colleagues or emergency room physicians or any physicians with this kind of extra level of information from a study that already exists is really a significant value proposition in many ways.
That's amazing. So what kind of requirements would an imaging center that has a CT scanner that wants to do CT VQ studies, what kind of requirements does that scanner have to have?
It has to be a scanner that was built in the last 25 years, or is being
Pretty broad.
routinely used, or is being routinely used for chest CT. Absolutely nothing exotic. That's what's. I think it's really important to point out that there is no unique requirement for that scanner. If they are clinically, if a site is clinically using a scanner for CTs of the chest, they have everything they need to perform CT-VQ analysis, literally not one other thing.
Okay, great. And what information does the radiologist or the referring physician in this case, which might be a pulmonologist, what kind of information do they get back from these studies?
Yeah. So, in fact, I want to say they both get back information. We provide information in line directly to the radiologist in a form that they would know well from other studies that they currently use. And I'll talk about that in a second. But fundamentally, there is a report, and that report has both quantitative values that will actually show the relative perfusion and ventilation in each lobe of the lung and in each lung separately. So they can quantitatively, non-subjectively evaluate the relative ventilation and perfusion, look for mismatches or matches of the ventilation and perfusion. The second set of data is qualitative images, images that actually show subjectively where the areas of defect are in both ventilation and perfusion. And we can return those images in a form, the form that most radiologists currently want to see those images. I think they would recognize most similar to a PET CT. So in a PET CT, we acquire CT images. We then acquire images using the PET component, and we display those images both separately and then fused with one on top of the other. And so we can return both the ventilation and perfusion image as a fused image with the CT. So unlike a nuclear medicine scan, they are not only getting the information about the ventilation and perfusion, but they're also getting the CT scan that they actually ordered, the CT scan that was already indicated, allowing them to make a wide variety of interpretive analyses even before they consider the ventilation and perfusion. So both subjective images and quantitative values. That report with the quantitative values gets pushed to the ordering clinician into the patient's electronic medical record, as it would with other standard quantitative tests.
Very good. Now, Trishul, you've worked with CT-VQ and you've received some of this data. What do you see its value as being, and how do you think it could change patient management?
A couple fold, Brian. So when we think about the nuclear medicine market, it's a $1 billion market. Greg has mentioned there's a couple limitations with standard nuclear medicine tests, namely price, obtaining rare new isotopes that you have to inhale and inject, time to do the scanner. And also the other component is that we share these scanners with our cardiology colleagues. And so a lot of these tests are the same sort of devices that we utilize to look at cardiac stress tests. And so there's a large demand for these devices and very few centers that do these tests and very few nuclear medicine physicians that read these tests. Almost every emergency room and every hospital in this country has a CT scanner. And as Greg mentioned, those CT scanners in the past 25 years can produce this study. And so if we can expand access, it can greatly reduce the time it takes to obtain these studies and also improve overall care and availability and affordability of these tests. So it has the potential to really change the overall market and more so improve how I, as a pulmonologist, see patients, where I'm not waiting a month to get a scan back. And we're not waiting 2 months to do a surgical resection or an endobronchial valve or even a lung transplant. And so in terms of thinking about cost, time, and overall patient experience, the opportunity here is pretty large.
Very good. Now, Greg, you mentioned that CTVQ got FDA clearance earlier this year. What have been some of the early results that are coming out from the technology? And maybe can you talk a little bit about how well it agrees with traditional nuclear medicine VQ scans and maybe even another CT technology, dual energy CT?
Sure. Yeah. So our validation of the technology, both before, during, and after our period of FDA clearance and our submission to the FDA, focused really on two main criteria, both looking at a quantitative evaluation, looking at simply direct comparisons using mathematical analysis of nuclear medicine VQ in the same patients that receive the CT VQ, and then carrying out direct voxel by voxel quantitative comparisons. And the same with dual energy CT, which you've mentioned, which is a newer technology that's used on there's a specific hardware that's needed to have a dual energy CT scanner. And patients also need injected contrast for a dual energy CT scan. But they're capable of producing something called an iodine perfusion map. So it's another technology where we can get a direct visual appearance of how blood is distributing itself within the lungs, which is the value proposition here for nuclear medicine, dual energy, and CTVQ. So we've compared quantitatively to those technologies, as well as some comparisons with even more cutting edge, newer technologies that are still in the research space, like the hyperpolarized xenon MRIs that have looked at perfusion in the lungs. We also carried out subjective reader comparisons. So for instance, we had a study where we had 6 readers who evaluated a cohort, 3 different cohorts of patients who had both SPECT VQs and our CT VQ, and then breaking the lung into 6 zones across 6 readers that have experience in radiology, thoracic radiology, nuclear medicine, directly comparing their scoring of each zone of the lung in both technologies. We had targets that were given to us from FDA and other sources in the literature, and we exceeded those targets, I'm happy to say. So we have since carried this study out on a lot more databases, both large publicly available databases and on patients that we work with. And we're just finding really strong concordance between both the quantitative and the subjective. We even took I'll just say this quickly, we even took a group of patients, one of the large groups that we tested, we had a lot of physiologic data on these patients. For instance, DLCO, which is a direct measure of diffusion across the membrane in the lung of carbon monoxide. And we actually found tighter correlation with DLCO to our technology than to SPECT. Now, I mean, this is all data for clinicians to use however they see fit, but we were really satisfied to see that, because it tells us that we are reflecting an underlying physiologic principle that's occurring in the lungs. There's literally something happening in the lungs that we are capturing. It is not, I don't want to say not just image changes, because I'm a radiologist and image changes are very important to me, but we are absolutely looking at the actual process underlying, and it was seeing those changes in DLCO that was so rewarding, that told us that.
Very good. Now, Trishul, we've been talking about this as an application for detecting pulmonary embolism, but there's a lot of other lung conditions that it could be applied to. Can you talk about some of those conditions and maybe how you might see CTVQ as being valuable for that?
Yeah, I mean, obviously, we think about pulmonary embolism as a ventilation perfusion mismatch, but every pulmonary disease ultimately has a ventilation perfusion mismatch. One of the reasons why we haven't utilized functional lung imaging more regularly for assessing things like asthma and COPD is this the cost and the encumbrance for these technologies. And so I think a lot of us in the field are, if there was a low-hanging fruit or a low-cost, easily accessible technology, we could perhaps see this really utilized. The most common applications beyond pulmonary embolism are going to be transplant, endobronchial valve placement, lung volume reduction placement. These are procedures that occur regularly throughout hospitals in this country that require nuclear medicine scans prior for pre-surgical planning. And so this is one way where we can utilize scans already obtained and apply basically the same matrices and not necessarily have to put patients through these additional testings.
Can you go into a little bit more detail on in terms of its value for lung volume reduction and how it might impact workflow there?
Yeah, so lung volume reduction surgery has been around for about 10, 20 years. And the ideas are that we're going to remove a bad part of the lung, and that's a very, very simplistic approach. But when you remove a part of the lung, you need to understand what component of that is aerated, so ventilation, and what component of that is being perfused. If you remove a part of the lung that is being perfused and potentially not ventilated, or ventilated and not perfused, it changes the entire paradigm of the lung because the lung is a single entity. And so this is perhaps one of the largest use for concurrent nuclear medicine scans. But the ability for us to use CTVQ within CTs, but more importantly, pre and post, right? And so we can look at before, and we can look at after, and we can even look 6 months to 12 months down the road, because this is a test that can be easily obtained. It really changes our overall approach in understanding pre-surgical management, but now post-surgical management. Who's responding to these therapies and why? Whenever you can do a procedure more frequently with a lower cost and a lower dose of radiation, it's always going to be more valuable to the patient.
Brian, one of the things I've learned in this journey as a radiologist who doesn't spend a lot of time in the nuclear medicine department, and many of your radiologist fans and listeners come from that experience, I know VQ from my clinical practice as being used when patients are suspected of having an acute pulmonary embolism but cannot tolerate contrast injection. And so what I've learned is that many radiologists think that is the most common application of nuclear medicine VQ. And I've even talked to, chiefs of departments who were unaware how many nuclear medicine VQ scans were being done that were being routed directly for these procedures that Trishul is talking about. It is by far the lion's share. And that was a real surprise to me, and I think potentially a surprise to some of your radiologist listeners.
For sure. Now, Trishul, you mentioned earlier about kind of the limited access to nuclear medicine and how it's kind of hard to get time on those scanners. How do you think having access to the much broader installed base of CT to do VQ studies is going to affect the patient care pathway?
The fundamental paradigm shift. These nuclear medicine scanners are very much oriented towards cardiac risk stratification and all sort of the downstream components of that. VQ very much presents a secondary sort of gain for these scanners, as well as implementation of the technology. And so our ability to utilize existing scans that are being done on a regular basis, and being essentially able to add on just a random overlay for VQ, it could really change the overall approach, not just for those individuals that are scheduled to get nuclear medicine scans, but think about other individuals that are just getting regular scans, right? For COP, for asthma, individuals that we normally wouldn't even consider getting a spec scan because we don't necessarily want to back up the process. We have the ability to expand this technology widely, just being way beyond the research component into a real clinical sphere. I will post a caveat, right? And so we definitely need to understand what is the benefit of expanding this technology in these subgroups and how does it improve outcomes. But it gives us the potential to even think about those opportunities where we just didn't have that before.
Now, Greg, can you walk us through the process if you've got a site that your company 4D Medical is working with the site that's interested in adopting CTVQ? Can you walk us through that, like how, what's involved in the installation and
Sure.
maybe what would be the turnaround time, that sort of thing?
Sure. So, as I mentioned at the beginning of the talk, we actually have quite a large portfolio of pulmonary focused products. That's what 4D Medical is all about. Is we have the largest portfolio of lung and cardiopulmonary tools out there for radiologists in current use. We perform tens of thousands of scans clinically per quarter right now. And so it's really just a simple extension of our existing solution. We are a cloud-based solution. Images are acquired, and as they are now for, as I said, thousands of studies, the image is then de-identified, transferred to us, and then returned directly into the PACS where it is re-identified. And those images are then matched with the input images, the inspiratory, expiratory CT scan, and made available. The current turnaround time on CTVQ imaging is about 30 minutes. We are interested in making that shorter. I'll say that 2 years ago it was well over an hour and a half, and it's dropping quickly. And so as you look at turnaround times, even in acute settings, turnaround times and service level agreements that we have as clinical radiologists interpreting images, we feel comfortable it's going to fit well in there, especially with the large number of studies that are done for scheduled procedure planning or post-treatment evaluation.
Yeah, sure. Greg, is there ever a time when you think that maybe it wouldn't be appropriate to do a CT VQ study, instead do the nuclear medicine VQ exam?
I'll say this. I've presented this technology to a large number of nuclear medicine physicians, and they haven't told me one. They are among the most ardent supporters of getting this technology deployed for many of the reasons that Trishul said. But I don't want to rule that possibility out. Not being a nuclear medicine physician myself, I think it's a great question. Maybe there are applications where there are other studies that are being done in the department, or high-end academic applications, that I don't want to misrepresent, if you will. So it's my impression, having now spoken with lots of physicians across the spectrum, that if they could do fewer nuclear medicine VQ scans now, I haven't heard a principle for continuing to do them.
Right, very good. Well, it looks like our time is just about drawing to a close, and I'd like to give you both a chance to kind of close with some final thoughts. Trishul, can you speak a little bit to how you think that this CT VQ technology might change your work as a pulmonologist and the care that you provide for patients?
Yeah, I mean, Greg mentioned something called DLCO, and that's a measure that we get from pulmonary function tests. it's limited. It has to do some component of effort and some component of readout from pulmonary function tests, and it doesn't give you any idea of where in the lung there's disease occurring. I see a future where we can utilize standard CTs that patients can obtain in minutes, where we can get a plethora of data to understand how they breathe, why they have shortness of breath, and inform us in terms of how to treat that disease. We are certainly a long way there, but the application of this technology and other technologies will get us there. And so it is utilizing existing modalities and low-cost approaches to really expand access and expand care. And that's what excites me when I think about the future of pulmonary medicine.
Very good. Greg, how about you? Some kind of closing thoughts about CTVQ and what it might mean
Yeah.
for patient care.
Yeah, I am what a big part of what we are doing in having now sort of developed the technology is looking at how reporting of this technology should be developed. And we have recommendations, but I'm so fascinated in hearing from the community of users, both in imaging and in clinical medicine. We are looking at tools to report direct information about mismatches as opposed to just subjective information about what the images, quote, look like. I think the final point that I'd make about that, that I really would like people to understand is this technology actually is not based on machine learning. This technology is not based on AI. There's so many amazing tools out there, and obviously, and we have some that are based on turning existing studies and some clinical information into an outcome. But this is mathematics. This is strictly calculation from these image sets and ongoing sets. So there are no issues of demographics that are inappropriate, overtraining, or demographics for whom the study will not extend. I think everyone, all of us who are excited about AI are recognizing some of those hard limitations and hard barriers. And so, the idea for this to move into a wide variety of applications because of its fundamental mathematical evaluation, I think makes it almost unlimited.
All right, those are great points. Well, I'd like to thank Dr. Greg Mogel of 4D Medical and Dr. Trishul Siddharthan of the University of Miami for being with us today. Gentlemen, thanks so much for your time. It was a really fascinating discussion.
Thank you, Brian.
Pleasure. Thank you.
All right, signing off for the Imaging Wire. My name is Brian Casey.